the Get in Position Foundation Affiliate Program, corporate and business partners, healthcare professionals, faith-based organizations, and nonprofits. Become an official affiliate for this initiative. Say No Kidney Disease. Take part to help encourage individuals to speak with their doctor to get tested, to know their kidney functions and understand the numbers. You and your organization will be empowering and equipping communities to get in position as it relates to their health. Visit our website to apply today.
Welcome, everyone, to the Kidney Korner Podcast. I am your host, Craig Merritt. I'm also the founder and executive director of the Get in Position Foundation, where we empower individuals with kidney disease to take control of their health journey in underserved communities through education, counseling, and personalized support. Our main motto is get in position as it relates to your health. Today, we got a very exciting show. I'm excited about it. We have a nephrologist joining us today, Dr. Julie Wright Nunes. I'm gonna read a little bit about her in her bio. Dr. Julie is an associate professor in the Department of Internal Medicine, the Division of Nephrology at the University of Michigan. That's big, folks. The NCAA champs. Go Wolverines. Woohoo! She is a health service researcher with a focus on optimizing patient-provider communication and patient education programs. That's real big. That's something that we do here at the Get in Position Foundation, Inc. Also, with kidney disease, achieve the best possible outcomes. That's awesome. She got a whole bunch of other accolades. I'm not going to belabor the moment. I'm going to bring in our special guest today, Dr. Julie Wright Nunes. Welcome, Dr. Julie. How are you?
I'm doing great, Craig. Thank you for inviting me to be here. And I just want to say at the onset, thank you for what you're doing. Thank you on behalf of not just clinicians, but obviously all of the patients and really the greater population, because what you're doing is so important. So thank you.
Oh, thank you. Thank you. I appreciate that. And welcome to the Kidney Korner.
Thank you very much. I'm excited to be here.
Awesome. We're glad to have you. So here on the Kidney Korner Podcast, one of the things is it's from a patient perspective. I myself, I'm a 2-year kidney transplant recipient. Woohoo! Yes. So I've dealt with kidney disease for 26 years. I was first diagnosed in 2000, stage 3 with FSGS. It was due to overdose of NSAIDs. I was taking painkillers and it caused damage to my kidneys. And so that's part of my story. And since the transplant, we started the foundation and we want to help other kidney patients like myself to get healthy or to get in position. Right.
Yeah.
And so today, I wanted to bring you on, and you and I met doing a live event for Kidney Action Week for AKF, the American Kidney Fund. And we talked a lot about a lot of high level things about the kidney. We talked about the kidney, what the kidney does. And that's really a very important subject for me. But we're going to get into some other things. Okay?
Awesome. Sounds good.
We're going to get right to it. I got some questions here. I want to get right to it, Dr. Julie.
All right.
And one more other thing. Congratulations, the Wolverines, NCAA champs. Yes.
Yes. So please go blue.
Go blue. They did their thing. All right. So I want to get right into it. Usually kidney patients, they crash, right? And that term in our world is they just go right into dialysis. And it's sudden. And 9 times out of 10, the question is asked, how did this happen? From the kidney patient. So, and the other question is, why me? Now, you may not be able to answer that second part of the question, but what happened?
Right.
What happened? Tell us what happened. Why did they crash? What happened?
Sure. So, great questions. You're right. I probably can't fully do justice to all of maybe the reasons or the causes, but certainly I've dedicated my career in medicine and specifically all of the research that I'm doing to try to fix the kind of the first point you made, which is about people crashing into dialysis or crashing into what we call the end stages of kidney disease. So ESKD, we love our acronyms. And I know I'll try to keep it not too high level, but unfortunately we love in nephrology, the study of the kidneys, we love to have jargon. So anyway, I think as far as people crashing in, so what does that mean? First of all, it means that people have very advanced kidney disease. There's 5 stages, right? So they get to that last stage of 5, which is the most severe, where we're actually talking to people about trying to hopefully already have them listed potentially for a transplant, like you were able to get. But oftentimes there's wait times for that. And you would probably know better than me and could speak to your patients and everybody tuning in today a lot more on that. But oftentimes we need other therapies to bridge to transplant. So those other therapies are dialysis, or if people can't get a transplant, then we have these other therapies called dialysis, and there's different types. So when people crash, basically they're coming to me or another clinician, and they have no idea they have a kidney problem or something called chronic kidney disease that, again, we love an acronym, so CKD. They don't know that they're at the advanced stages of this. One of the reasons is that kidney disease is common, but it's silent. And it's silent until its very end stages, the very more advanced stages. And in those advanced stages, people might start to feel symptoms of the end stages of kidney disease, which could be nausea and vomiting. They're losing or gaining weight. They have shortness of breath. They might feel a little fuzzy or confused. Their blood pressure is going up and they don't know why. And like I said, swelling, and it can be around the eyes or the whole body or mostly the legs. Now, this can happen too for people whose kidney function changes super fast. We call that acute, but kind of, again, keeping the terminology for something that even I would appreciate because I've been a patient before. So super fast worsening of kidney function, we can see that too. But regardless of how people are getting there, when people crash, they're at the advanced stages. They're maybe starting to feel some symptoms, but maybe not. And it's all a big surprise. So they're coming to see me because somebody maybe did a lab test because the patient isn't feeling any symptoms. And it's showing, oh my gosh, their filtration is very low to the point where their kidneys can't really clear the poisons that we build up just as part of day to day, can't clean the blood like it should, can't balance the blood pressure like it should, can't keep the fluid out of your legs like it should. And then we are very rapidly, kind of part of that crash, rapidly trying to get people on therapies to slow the worsening of it and to really delay initiation of dialysis as long as we can safely. Because once you're on it until you get, if you can, a transplant. And so that's what the crashing is. The reasons, in addition to it being silent, so people not really seeking perhaps care earlier like they might for something that's giving them pain, a condition, is really systemically. I don't think within healthcare, and this is part of my research platform and part of what I'm dedicated to, part of the reason I went into nephrology is because we really do need better systems of care within chronic kidney disease. When you have a silent condition that people might not even feel until they're needing dialysis or a transplant, then we need to be very proactive in that as a community. And that starts as a medical community. And we need to be getting the word out to the public about what the kidneys are, what the kidneys do, how important they are. And that starts, prior to adulthood, in my opinion. It starts with youth. And so that's also part of my research. We can talk about that later. But as I've learned and seen so many adults who maybe I have to take a step back in my clinic and talk about what kidneys even do when they're coming to see me, and I'm thinking, golly, they're very close to dialysis. That's not the time I want to be educating anybody, whether it's a patient or the general public, about what the kidneys are and what they do, right? You want to be spreading awareness, having people understand, just like they might about the heart and what it does in general, or the brain. I think people, hopefully, one of my goals is to work towards people understanding that and having their own awareness and advocacy. But as a medical system, I think we need to improve that too. We need to be having outreach out in the public. We need to be educating through science about what the kidneys are and what they do. And then we need to be screening people at high risk. Maybe I would make a case that everybody should be tested for their kidneys and see what their filtration is and what's going on in their urine. And we can talk about that later. But there are some groups that we know are at a little bit higher risk for getting kidney disease to begin with. So as a medical professional, starting in primary care, making sure we're doing the screening that we should be doing for individuals, checking people's labs to see if they have any early signs of kidney disease, and then letting people know about it. Part of the bigger picture of what I see, Craig, is not only people crashing into learning about their kidney disease at advanced stages, but people having seen a clinician in primary care. And I'm not blaming primary care, because I can tell you all about research that shows even in nephrology, we're not doing a fantastic job or as good as we should about educating people to their chronic kidney disease, and we're kidney doctors. So, but people who have seen a primary care doctor for years, and the primary care doctor's been watching their kidneys and maybe even talking about their kidneys with them, but it doesn't really set in maybe in the same way unless we say the words chronic kidney disease or there's a problem with your kidneys. And sometimes what happens more commonly than crashing is that people come to me when they have moderate reduction in their kidney function, or it's not super advanced, but kind of middle stages of kidney disease. And they ask me, well, now I understand I have it, but where was everybody before telling me about it? So I see that a little bit more than crashing myself. They're both things we have to work on. So sorry, that was a long-winded thing because I'm so passionate about it, but I think it's systemically across awareness. It's systemically across our medical systems and providing more education and proactive care around screening. And then really making sure people understand as a baseline what the kidneys are and what they do and their importance to health.
All right, so that clears up all the questions I have for you, Dr. Ju. Thanks for joining us.
I'm so sorry.
On the
You can tell I'm
Kidney
very
Korner
passionate.
Podcast.
I will try to keep it more
No.
concise next time.
No, you're fine. You're fine.
You can tell I've been thinking about this for the 15 years I've been in practice.
Yeah,
right?
I mean, where do I go next? Let's see. Let's see. How many kids do you have? No.
I have one. I love them. Yes.
No, you. Wow. That was amazing. There was a few things you mentioned in your answer, and I want to touch on.
Sure.
One of the things is you said silent. And I want your take on this, Dr. Julie. I have been saying that I don't think it's silent. I think it whispers.
Oh, I like that.
I think there are signs, because for me, when I think back to my situation, and when they finally discovered that, okay, you on a routine primary care doctor's visit, they were alarmed by my blood pressures. I was 29 at the time, and they were really alarmed about why my blood pressures were so high. I was having headaches and stuff like that. And so I did, once I learned more about some of the symptoms, it was like, I was like, yeah, I did see that, but I didn't know what it was. And I kind of ignored it. So that's why I say it's not silent, it whispers, because we get so caught up in feeling.
Right.
We get so caught up in how I feel.
Mm-hmm.
So do you think we need to start changing the verbiage here or the message? And you did mention about education, which is, I agree with you. We need to start educating and bring about more awareness of disease. A lot of people are not paying attention to it because we're so hung up on how I feel.
Right.
So what's your take on? Give me some feedback on that terminology of it's whispering.
I love the terminology, and if it's okay with you, I will attribute it to you, Craig. But I'm going to start using it.
No problem. No problem. I need to trademark it. But yeah, I think it's whispering. Mm-hmm.
Right. So I think it's actually both. And this is only from my patients and what they tell me. And thank you so much. I just, again, love the fact that you have been there and this is part of what your journey is and you're willing to share it. So thank you.
Mm-hmm.
And so first of all, I do agree that there's a whisper. And I think those whispers get stronger to even a shout sometimes with some of my patients. So a lot of my practice, I see patients with all different kinds of kidney conditions. And, we call chronic kidney disease one term, but it's a catch-all term for a bunch of different things, which can be very confusing.
Yes.
But a lot of the patients I see, regardless of the causes, the multitude of causes, are advanced or have advanced kidney disease.
Hello, everyone. I'm Coach Woody, your dedicated kidney health coach from the American Kidney Fund. You are now watching the Kidney Korner Podcast. Get in position as it relates to your health.
And I am getting them ready sometimes to start dialysis. And so I feel like those whispers are there for them as far as symptoms. So they might be feeling something's a little off. They know their body best. And I tell them that, you know your body better than me. You kind of know what's off. And it's kind of seems maybe weird to have a doctor say, well, you know better how you feel, but you do know better how you feel. And so that's why there needs to be a partnership. But they get those whispers and they become more strong related to their symptoms. Yeah, maybe they're just eating a little bit less, but it doesn't feel really bad, kind of like you're saying. It's just something that they're dealing with. And yeah, maybe there's a little bit of swelling in the ankles, but yeah, that doesn't feel too bad either. So I don't need to take the next step. Or maybe I don't want to add another medication to the many that I have. Or maybe I don't want to start dialysis quite yet, even though my labs look not the greatest. And so that's where I feel like that whisper gets stronger and it's actually becoming a shout. And just because people have lived with what they've lived with so long, that they do almost become like immune to some of the symptoms. So I agree with you, there are whispers. And I do think that they're earlier stages as well as yours may have been when you were younger. And that if you look back, you're like, oh gosh, yeah, that was connected. So I do agree with that. I also have on the flip side though, many patients who say, doctor, I just wouldn't know. I wouldn't know at all that I had a more advanced stage for chronic kidney disease had you not told me that. I'm absolutely shocked. I'm, active as I always have been. I'm eating as I have always been. My blood pressure's good. And so I do think that there is a continuum, but I love the fact that you talk about the whisper. And I think that's important to hear that whisper. And maybe we don't as patients and as providers, maybe if it's a whisper, well, that's good enough because it's not a scream. It's not a shout. We don't have to address it yet. And so I think what you said is really important. And like I said, I'm going to use it. I'll be asking my patients, are your symptoms whispering to you or
nice. Nice. Good. It's going to a great cause.
right.
Good. I don't mind it. Have you ever served as a nephrologist in a dialysis center?
So not currently. I have in the past, in other positions, and I do dialysis in our acute center, but that's inpatient. So the way we're set up, it's just how we're set up here at this institution. That wouldn't really be common for people, certainly out in more community practices, and maybe is a little bit similar to other academic practices.
Okay. So the reason why I asked that question, Dr. Julie, is because as a former dialysis patient myself, there were a few things that I experienced, and some of our viewers, our kidney warriors out there watching today, shout out to them. There are a few things that they struggle with while on dialysis, and hopefully you can clear up some of these things. One of the things is blood pressures just plummet. They drop. The blood pressure's dropping. The cramping. The cramping. Also the draining, like you just feel so tired and drained when you come off of dialysis. If you can give us some insight, give the viewers some insight, some of those dialysis patients, and also we're not just speaking to the dialysis patients, but we're speaking to the caregivers as well, or family members who may not understand what's happening. When we come home, cramp today. I feel like crap. You know, why does that happen? And sometimes it happens often with some patients. So, what's the reason for all of that?
Yeah, that's a great question. And I think if I were to try to sum it up into kind of a big picture thing, and then we can drill down a little bit, is that if you think about what your kidneys do, I think the kidneys are humble organs. You know, they kind of hang out in the background and they clean things for us and clean our blood and do so many amazing things to keep us healthy. But they don't get, like I said, you know, like the heart, they're not kind of up there as far as fame.
Right.
But we sure know when they don't work, right?
Yes.
And so if you take what these humble organs are doing 24/7, and you think about what you're doing with dialysis, you're actually trying to compress what they do 24/7 during your life into 3 times a week short sessions. And so the big picture is, if you think about that physiologically, that's pretty intense. So to me, the big picture, as I explain it to my patients, is think about everything the kidneys were doing, sleeping while you're eating, sleeping, going about your day prior to needing dialysis. And now you're trying to have a machine kind of help you take care of what the kidneys did, but you're compressing it into 3 to 4 hours once a day, 3 times a week, maybe 4, right? So that in and of itself is tough on the body. So that's kind of the big picture. If you talk about kind of, did you want me to delve into it a little bit more? Like some of the reasons with the blood pressure and some of the,
yes,
okay,
please.
yeah.
Because people want to know why does this keep happening? Yeah, people want to know.
Right. So you can get rapid fluid shifts, as you know, again, better than me. We're taking an amount of blood out of the body, we're putting it through a machine. And when you get large fluid removal, you can get intravascular inside your blood vessels. You're going to have less fluid, you're going to have less blood. And those shifts can decrease temporarily the blood that's going to other parts of your body, your brains and your muscles. And that can be fatiguing. And then you could also get blood pressure drops because you literally don't have part of your blood volume in your body. So that's going to be, and some people can take that easier than others, but everybody has a limit. And then on top of that, you're trying to remove fluid, right? So you're not only having part of your blood outside of your body in the dialysis circuit, but you're also trying to take fluid off of a person. And again, if you're doing that over 24/7 over 7 days a week. It can be a lot gentler, but the machine is trying to do it in 3 to 4 hours. So that is hard. That's what's going to drop that blood pressure because you're removing that fluid too. So then you don't have it in your blood vessels, and then it's not going to your brain. It's not going to your heart. It's not going to your muscles. And that's really fatiguing, and it can drop your blood pressure too. And then one of my mentors, one of many individuals who work in this area, but he has done studies showing that dialysis is a kind of a catabolic process. And so that's kind of a big word, but basically we have muscle and tissue build up and breakdown, right, as part of us living. And we eat and we try to replenish our stores, but that's just part of what we do. And, if you're running a marathon, you're going to have a lot of breakdown, right? And I'm not saying that dialysis is running a marathon, but it is a catabolic state. It actually is, there's protein breakdown in your body, there's energy depletion, and that's been shown through studies. And so that also contributes to how people might feel.
Wow.
Yes. And then there's like other things. I mean, you have these things called electrolytes in your blood, sodium, potassium. I'm sure people have heard of that in your podcast. You have too. And on a really micro scale, those things interact with muscle tissue, and your brain and your heart, and to keep things going in your body. Right. And you're changing those during dialysis. So you're going to have shifts of these things moving in and out of muscles, and that can affect your muscle function. It can affect your heart stability, and it can affect your overall energy as well. And then on top of all of that, you're also dealing with things like low blood counts. So we call that anemia. So that's part of the kidneys, and the kidneys make a hormone that helps keep those blood counts up. Yes. And during dialysis, some people might get part of that hormone delivered to them during dialysis so that they don't become what's called anemic. So that's when your hemoglobin, red blood cells are low, and that affects oxygen delivery to parts of your body, and that would make you very tired too. So on top of everything you're getting done 3 times a week and all these shifts, like I said, you have these other conditions that we're trying to treat that also contribute to fatigue. And in general, I feel like you said warriors is a great term for the people who are walking this journey and watching your podcast. I think they're also heroes, because to me, they're running like a mini marathon 3 times a week. Oh yeah. And no wonder you're tired, because of all of these things.
Wow. Yeah. And I think that's a huge topic or issue that you brought up as far as the anemia, and most dialysis patients, they try to figure out, why am I so cold, and it's so cold in here. And you see when you go in these clinics, I'm talking about in-center, why everybody's wrapped up in blankets and so on and so forth. So it's because of that. And I think if we have a better understanding of what the kidneys actually do, I think there's such a huge highlight just on, it cleans the blood, it filters the blood. But, I try to promote, hey, that little organ is powerful. It does a lot. It does a lot. And you said in the background, there's a lot that we got to do. Just like when you watch a movie, at the end of the movie, there's credits. This is the only illustration that I have. There's credits. And sometimes you can be sitting there watching the credits for like 5-10 minutes, like, yo. But understand, they have to give credit to every single person and job and position that helped this movie come to fruition. Mm-hmm. So think of the kidneys like that.
I love it.
It's all of those things that this little kidney does.
So true.
It's a lot more than just the director, the producer, the cast, No, you got to have the lighting person. You got to have the electrician. You got to have the you got to have the costume. It's a lot of people, stunt people. You got to this kidney does a lot. So all of you watching and listening to this right now, I say get a better understanding of what that organ does. And it'll help, not to say it's not going to ease the pain. It's not going to do that. But now I have an understanding of why. I have a better understanding of why. So, and that helped me actually deal with it a little better. And then I could explain it to my team. I call it my team. And when we're teaching our mentees at the Get in Position Foundation, I teach them up front, assemble your team. And your team is not just your healthcare providers, but that's your caregiver, your family members, your spouse, whoever it may be. But assemble your team. And I believe that you and your team should be having meetings. And be transparent with your team. I'm not feeling well. I had a rough week last week. Here's how you can help me. Let's get some more education about what this thing is really about. Let's find some resources. So that's a great point. Understanding what is happening and why it's happening. And we got to remember that machine is not providing those other services
right,
that the kidney does. Right.
And the other.
Go ahead.
Well, and the other thing, so many good points, and love your analogy with the credits at the end of the movie. I think that another important thing to realize is the machine, even though it's doing as good of a job as it can, and we try to give people enough dialysis to make them feel good and continue to live productive and great lives, it still doesn't equal what kidneys would normally do. It actually still only gives you about 20 or 25% of what you would get with your kidneys. So dialysis is not equivalent to totally, let's say, making it be like you have normal kidneys. Does that make sense?
It does.
So I don't think I'm saying it quite right, but it actually will only take you to having advanced kidney disease. Even when you're getting dialysis, it's still going to take you to that level of cleaning the blood. So it doesn't totally replace 100% all that kidney function. And that's hard on people because, as you said, there's whispers of symptoms, right?
Right.
And so I do believe, through what patients have told me, and hopefully was your experience, is it does make people feel better overall, but you're still at risk for the whispering of the symptoms because it's not clearing your blood like a totally normal, healthy kidney would do. I think the other thing related to, you brought up a great point about people being, I think what I heard was people being comfortable where they're at. And I am very sensitive to temperatures, too hot, too cold. You can't please me. I have a fan, turn it off, so if you're at a place that's going to be a place that you're going to be at for 12 hours or more a week, all of that matters. The comfort of it matters. And when you're freezing, that makes the experience maybe even not as comfortable as it should be when you're spending much time there. And we do maneuvers with dialysis machines, hopefully in concert, talking with the patient, but we can cool down the dialysate. We can make it colder. So if people's blood pressure is dropping, that colder helps the blood vessels constrict a little bit, get smaller, which helps your blood pressure stay up. So I'm not saying that's a reason that everybody might be getting cold.
Right.
And that's not very often, but it can be a maneuver that's contributing to how people are feeling too.
Oh, wow. That's some good information. I hope you guys are listening. Early on, you talked about, and I was so excited. I wanted to jump up with that, but I wanted to save it. Your take on self-advocacy. Okay. Now, again, this podcast is from a patient perspective, and these are experiences that myself and some other patients that I know have experienced, that there may be some, I guess, hesitation about advocating for themselves. Some people don't know that it's important to advocate for themselves. Some people, when they do, they get pushback from their healthcare team. And that kind of deters them from, I'm not going to say anything and so on and so forth. And but let's talk about the self-advocacy piece, or advocacy period. What's your take on that? And what would you say to our viewers out there? Most of them being patients, dialysis patients, kidney patients, some of the caregivers listening to this podcast, this episode. But let's talk about the advocacy piece.
Sure. Thank you. Such an important topic. And yes, one that I'm very excited about and passionate about as well. So I would say that in a maybe perfect world, which is not the world we're living in,
Right.
we wouldn't have to be such strong advocates for ourselves in medical care, because you'd have your clinicians and the systems around you supporting and knowing what you need in advance and providing it to you. And I do feel like within medical systems, and I certainly hope that we do strive for that, but we clearly missed the mark of, because otherwise, how could 30% of the people who see kidney doctors not know they really have chronic kidney disease? Like, how can that be, right? So clearly there's something that's missing. Or people come to me and say, gee, I never heard this term chronic kidney disease, and you just said I have it. What does it mean? So there are gaps that are, to me, opportunities that I've been trying to address through research on the clinical side to support the clinicians. And I'll talk about that in a minute. But what I've learned as a patient, not a kidney patient, but as a patient, having been through hospitalizations and some pretty serious diagnoses myself, even as a doctor, it is hard for me to sometimes, it's not hard for me to speak up on my behalf, but it's sometimes I feel deferent a little bit. I'll defer to my clinicians because I think, well, you're the expert. And who am I to, debate with you? And here's what I realized through my own medical issues. They are the experts, hopefully, right? But they're also humans. And they also might have an agenda that is to help you, but maybe not in all the ways that you need that help. So it is important for you to become educated about what your condition is, because otherwise you don't know what to advocate for, or maybe you can't quite put your finger on what it is that you need. And so, just as an example, using me, I was having some debate with my surgeons about a type of surgery I was going to have. And what I realized is when I poked around and asked more questions about, well, what if we did this option or that option? Great surgeons. They were very receptive to hearing it. Maybe not all of them would have been, right? But then I realized, oh my gosh, if I hadn't brought up these other things, then maybe this other option wouldn't have been on the table. And that's, bringing it to patients. When I educate people about maybe something they don't want to talk about a lot, like when their kidney disease is progressing and they might need renal replacement therapy, which is just a fancy term for saying a type of dialysis, and hopefully a transplant, but that might take time. So when I'm talking to people about this, I want their input as to what type of dialysis they want, but they can't give me that information if I don't educate them first. And part of that's on me. But part of it, too, is when I offer them online classes or provide information, that's where we as patients need to really, I'd say, engage or try to be activated as well. And so long story, what am I saying? I think advocacy is important. I think not only is it important, it's critical. And whether we like it or not, we have to become educated about what conditions we have so that we can engage with our clinicians who hopefully have our best needs at heart, but they might not even know what they don't know about us. And so it's a two-part thing. I think what I'm trying to do in the clinical space is develop what's called decision aids or educational tools that we can use not only during kidney care, but in primary care. That's almost like a handout, but it's a kind of a prompt for providers, clinicians to talk to patients about their kidneys, but it also has is given to the patient so they can use it as kind of a guide to kind of write down what it is that they want maybe answered. And maybe it's not at that same visit, but somewhere along the line. So I think it's a dual partnership. And until we put a lot more mechanisms into place within healthcare to be more proactive about kidney screening, which we're working on it, but kidney screening and kidney treatments with quality collaboratives, some of which I'm working on in the state of Michigan. But until we're where we need to be, we're going to always need the patients to advocate for themselves too. And you can only do that with knowledge and education and understanding. If a person feels like they can't have that dialogue with their clinician, I've been there too. And that's a toughie, because if you like your clinician, you have a good rapport, you sure don't want to leave them. It's a kind of hard day and age to get good clinicians. So I understand that is a balance. But just like any other relationship, if you're not getting out of it what you need, I mean, this is your life and this is your care. So you need to find a different relationship. And if that's with a different clinician, then find a different clinician and keep going until you find one that's a good fit.
Dr. Julia, it is so refreshing to hear you say that from our healthcare providers. It is so. Thank you so much for saying that. That's one of the big things that we teach at the Get in Position Foundation to our mentees is that it's a partnership.
Yes.
It's a partnership between my provider and the patient. And I always teach my mentees that it's the business of you. I
love that.
And
you're the CEO.
Right. Thank you. That's it. And hey, I got to find a good partner. And you have to interview. We have to make sure this is a good fit for the business, right? The business, right? And so to your point, I'm so glad. I hope a lot of individuals who are watching this podcast, I hope you grabbed hold to that, what Dr. Julie said. Hey, it's not working. And the thing, what she's really saying, folks, is it's okay. It's okay to do that. You got to find the fit for you. You know, you may wear a large, but a 2X is not gonna look right. It's not gonna fit.
Right.
And especially when it comes to your healthcare, folks, you can't go get this off the rack. I need a personal tailor. I need a personal tailor, right?
Right. Right. Absolutely.
And I know to go buy that suit and that material, you know, when we talk about clothes, literally clothes, and trying to get it, you know, there's a certain echelon of people who can afford that, right?
Right.
But in healthcare, hey, it's I don't care what it costs. I do not care what it costs. My life depends upon it.
Right.
My life depends upon it, and I need something tailor-made to fit. Right? Someone who knows me, where we can partner on our treatment plan. Right? On our treatment plan. And so that's so important. I'm so glad you said that. Oh man, I'm so excited. I want to jump up at that, but I can't. I really do. No, that's liberating to hear a nephrologist say that. Thank you, Dr. Julie. That's why you the best. You the best.
Oh, thank you.
You're the best. You're the best. That's why you're here. That's why you're here. So what would you say to those patients out there? How would you tell them to prepare for a doctor's visit?
Right.
Because, all right, it may be some news I don't want to hear. I already have anxiety. I already have some reservations. But I think being prepared is really good. What would you suggest to them? How one should prepare for a visit?
Right. Great question. And that is important. And I don't know if I really even thought about that much until I became a patient myself with chronic issues. And I realized, gosh, the doctors, again, I'm grateful to, but they had to kind of get in and get out of the room. And get on to their next patient. And they did care about me, but they cared about me in those moments. And so I had to really kind of psych myself up to make sure, okay, I don't want to miss this. So one thing that can help is, first of all, knowing that there are limits and resources within medical care. And again, be it right or wrong, and maybe mostly not right anyway, is that there are limits on the time right now that we can spend with patients and certain visits, new patients versus return visits. There are demands with our support. And so when you're going into a clinician visit, just know that you shouldn't have to care about it, but the way it impacts you is that your time with that clinician is valuable, but limited. So, and it's not because that's the way the provider would want to design it. But it's just because of how the systems work and reimbursements work and the way we're set up right now. So we don't have limitless time with patients, and we try to make the most out of the time that we have. But some people seeing somebody who they've seen before might only have 20 minutes or 25 minutes at least allotted to them. And that's every patient. So I don't mind taking a little bit more with all of my patients, but then the person at the end of the day then kind of gets delayed. And so that's not fair. So within this current system, what I'm saying is, first of all, realize that. Mm-hmm. And the reason why I think that's important is that then you can strategize as to, okay, well, what are the things that maybe I want to get out of this visit? And list those as bullet points, and understand that if it's a list that kind of rolls out onto the floor, it's probably, we can't get to all of that in the visit, but put your top few priorities, and those make very clear to your clinician that you want to talk about these things, that they're important to you. Because I have things as a clinician I think are important to you and are not on your list. And they might be, maybe your potassium's high, and as that can affect your muscle, and your heart's a muscle. So I have to talk to you about this, even though you want to talk more about, can you eat phosphorus? So then, but it's good for me to know that. So in my algorithm in the clinical visit, then I can say, okay, I'm going to talk about this thing that I think can really hurt you, which is maybe my agenda, but we'll at least try to fit in some of your agenda, if not all of it as well. And if I know that in advance, and you have it on your phone, or you have it written down on a piece of paper, it doesn't matter, or just bring a person with you. Hey, loved one of mine, can you just remember to help me remember these things to talk to the doctor about? And what I've learned to do is to sometimes, as a clinician, I'll jump in, I'll start trying to talk to people and guide the conversation. Even if you have to raise your hand, literally, or just pause and say, that's okay, but I have some things. So can we just make sure we get to those two? Those are tactics that I've used, and I love it when my patients do. I think a good clinician, and what I try to do in my communication is I've learned to pause, and at the start of the visit, I say, first of all, ask me the questions that you have today. It's surprising how many people don't have questions. They're kind of used to a system where I'm just telling them things. And then, unfortunately you walk out of the visit, the doctor's gone, they've run on to the other patients, and you've like, bing, light bulb goes off. Oh, I thought about this. So, so knowing there's limited time, then strategizing for how you can help the clinician make the most of that time, I think are great ways to prepare, and they help me as a clinician support you as well.
Nice. You just gave us some jewels, and I hope individuals.
Jules by Julie.
Right. I like that. Jules by Julie. Listen, that's some good stuff, and we have to be better prepared when we go to our doctor visits. It's not just a visit; it's your time as well, and that's good to know. It is limited time, and I know that I hear it often from my mentees. I hear it from other individuals, because my thing is, everybody on the planet is a patient. You're a patient. Even you yourself, you mentioned,
Yes,
hey, when I
right.
go to the doctor, this is what I do. And I'm a doctor.
Right.
So, right. So and I love the humility that you have in it too, because it's just because you have a specialty, right? But I'm here to see something else. And so you're relying on that clinician to help you understand this, that, and the third. Now, you may know the terminologies better than a lot of us, but still you're a patient. Right. So
Right.
I have to be prepared, and I have to know. That's a big one. I didn't understand why it was such a okay. Thank you. Is that it? All right. Thank you, Mr. Merritt.
And they have their hand on the door.
Right.
Anything else? But my hand's on the door and I'm opening it. So,
Right.
yeah.
Right. No, that is so good to know, and also to keep in the back of our mind too, that we can get so caught up on ourselves, which that's fine, and you
It is
should.
fine. Yep.
Yes,
It's your job.
It's your job to worry about yourself. Worry about yourself. But also, there are other patients too, right? Because while you was waiting, they were in with the other patient, and you looking at what's taking them so long, right? So we have to, allot some grace. That's what
I do appreciate that. And again, I don't ever expect a patient to, sympathize with me in my day, as a clinician. That's not your job, and nobody should be asking you to do it. So if they do, reject that on the spot, it's not your job to worry about that. But yes, some grace. And I think just some understanding of why we might be acting or doing the things we do. I'm trying to fix that. I mean, we're trying to fix that. And it's not always the case with every clinician.
Right.
And we can do that with tools. We can do that maybe with some pre-planning. We can do it with some of the decision aids I'm making. But yeah, until we get there, then it's just good to know.
Yeah, absolutely. I want to move on to, this is a very important question that I have for you. You mentioned it early on about testing, and even here at the Get in Position Foundation, we have a new initiative.
Okay.
It's called Say No Kidney Disease, and the no is spelled a little different. It's spelled KNOW, but we emphasize the NO in the word no.
Yes.
So this initiative is, we're trying to encourage at least 1,000 plus individuals to speak with their doctors about kidney disease and wanting to know their kidney functions. Doing the two tests, the blood tests and also the urinalysis tests, to know their kidney functions. So that's an initiative that we have here. And we're trying to get the word out. We're trying to work with some other foundations, some healthcare professionals to join us as affiliates to spread the word, to help us get individuals tested. So talk about that, the importance of getting tested. Now, is it the everyday person? I know that for us, it's a focus on individuals who have diabetes, who are diabetic, and also those individuals who are or who have already been diagnosed with hypertension, high blood pressure. It's important. Like you said, you know that their primary care is probably watching it, but it's not a flag or alarming to them because of the numbers.
Right.
But as a patient who's dealing with because we know diabetes and high blood pressure is the two most leading causes of chronic kidney disease. However, there's some other genetic testing that individuals need to actually pay close attention to. Individuals like myself who are African American, there's a genetic gene that, you know, you could have it and don't know it.
Right.
That's high in the African American community and as well as the Hispanic community. And from some studies and some data I found, now we're seeing the Asian community rise in kidney disease now. So speak to how important this is, knowing your numbers, getting tested, what are the tests, and also the screening.
Sure. So that's a great point. And I will be honest that there's been, at least in the time that I've been in nephrology, even as a fellow in training, there's been some debate and maybe some changes on the emphasis of who should get tested. I remember when I was training in nephrology, this was probably 20 years ago, and I had the opportunity to work and observe some task forces related to U.S. guidelines. And there was debate on whether there should be generalized screening in the general U.S. population for kidney disease because there weren't any randomized trials or research proving that this kind of screening would help. We can debate about that as patients. We can debate about that. And we might not understand so much as humans or even sometimes from a research perspective, but that was kind of a bit of a debate. As things have come along, I think people are more, clinicians, our renal community, certainly the renal community is very supportive of screening and making sure it's done on, nearly everybody, at least, early in your life. And it doesn't mean that my 14-year-old son has to go get his kidneys tested. But, once you start seeing a primary care doctor, I would be hard pressed to probably find one that wasn't at least doing a blood test to check your filtration. And if not, a urine test as well. Mm-hmm. With that said, you're right. There is a focus on who should be tested that's more guideline based or more promoted. And it's certainly because what we said, that kidney disease is often asymptomatic or it's whispered to you. That's why screening matters more than waiting for symptoms or how we're feeling. Because if you wait for how you feel, that can be at advanced stages. And so there is a focus on, in particular, people who might be at higher risk for having kidney disease. So people who have diabetes mellitus, because that can hurt blood vessels in the kidneys and hurt the kidneys, high blood pressure. If there's a family history, and like you said, that might be related to genetics, but a family history, it's advocated for people to be tested as well. Cardiovascular disease, because there's a link between heart disease and kidneys and heart. We're learning more about it, but it's just a connection that's really important. If people are older, people define that different ways. And in high-risk populations. And in particular, you mentioned there's genetic testing. I don't know within our talk that we can go through all the different types of genetic testing, and there's so much that I would need to talk with my colleagues and experts on. But in particular, there's this APOL1 gene that some people, it's a gene variant, some people inherit it. It is more common in people of African-American ancestry. Historically, it was in place maybe to fight infections of certain types, but is now something that can confer risk for progression to end-stage kidney disease. People who have maybe cystic diseases, autosomal dominant polycystic kidney disease is a type of condition where the kidney tissue, healthy tissue, gets replaced by cysts, and there are genetic tests for some of those variants as well, and so those come into the forefront. So, to summarize all of that, of course, I'd advocate for everybody getting testing through their primary care doctor when they're doing their health maintenance. And I believe that in general is happening, even if it isn't something that's a huge guideline from the United States. Who should be tested is the high risk groups that I talked about, including people who do have that family history. As I said, the high risk populations with diabetes, hypertension, cardiovascular disease. And then the tests that would be done, if they're not genetic tests because there's something perhaps that's trending in a family or skipping around in generations, but still familial, certainly the test would include a blood test that includes something called EGFR, which is, again, the acronyms we love, but it stands for your kidney filtration rate. And that is super important. You can kind of, when you look at that lab value, it's a blood test, and you can think, well, you want your kidney engines to be running at 100%. So that number should be 100. And when it's lower than 100, it just means your filtration is lower than 100. You can almost say like it's 1% of the filtration. So that's one test. And then the other test is just what you said, a urine test. And that's easy, right? Easy peasy. You pee in a cup. They do a dipstick, or they do, and that can tell us if there's blood in the urine, which can be related to the kidneys or other issues. And then the protein is really the big one, a type of protein. And the reason that protein in the urine is not good is because it's a marker of the damage in the small filtering units in the kidney, because you want to keep that protein in the blood, but it's leaking out and getting into the urine. And so those two tests are really important. So in summary, like, we really want to screen more than waiting for symptoms. And I think that's what you're talking about, Craig, when you're doing this movement. I'll do whatever I can with my patients, though they're all getting screened, several times a year because they're kidney patients. But yes, getting that out in the community, kudos. That's fantastic.
Awesome. Thank you for that. So, all right. We talked a lot about different things, advocacy, getting tested, what the kidneys do. What would you, Dr. Julie, as we wrap things up, what is it that you really would like to see more of from patients in this community? What are some of the things that you would like to see improvement on? We're not doing enough of that helps not only the patients, but helps their healthcare team.
Yeah, I think where we could use, so I'm pausing a little bit because I do feel, at least in my current practice and probably more in the last decade, that people are engaging with me in care. And by that, they're partnering, they're asking the questions. When I say, do you have any questions? Most of the time people will have them. Sometimes they don't. But that's okay. I mean, you don't have to. But I think that's one of the things that I would want to continue. And for patients, I've rarely had some patients say, well, I don't really want to hear about my kidney disease, but you can tell my loved one who's sitting next to me here, I don't really understand that psychology myself, but okay. But I do kind of probe into that because, like you said, you're the CEO of your health and your life. And so I think, well, why are you giving that CEO role over to somebody else? That's something we can delve into another time. And if it works for them, great. But I do feel like owning that CEO role maybe then can help empower you and me as patients when we are talking with our clinical team. And especially when there's things that they may not know about us, or again, might not have considered when they're thinking, oh, here's a traditional route of care, or this is a traditional thing we're going to talk about. I think it opens up that dialogue. So I'd look for continued engagement, the advocacy that we talked about, and asking the questions. And I think outside of being a patient, what you're doing, and I'm not just saying this because I'm talking to you on this podcast, but things that you're doing like this, you're raising awareness, and we need more of that. And if people are willing to share their stories, maybe they're not, and it can be private, and that's okay. But I think that goes such a long way in making other people feel comfortable to share their stories, and then talk about, okay, well, we maybe already have this condition, but what can we do to prevent it? And what can we do to help the Julies in healthcare make things better? We have partners now, patient partners in research, helping us with those opportunities, because I do feel sometimes like we're a small community. People are busy and they're just doing the best they can in their lives. And if you have a chronic medical condition, that's pretty tough. So I don't expect everybody to be going with us to Capitol Hill and making a case for more funding or screening or emphasis. But those of us who can, I'd say, let's partner together and do that. And we can do it in formal ways as well. But it's through looking through those opportunities, watching your podcast, joining you with getting that 1,000-person screening or beyond. I mean, that's what I would love to see continue even more.
Awesome. Well, Dr. Julie, thank you so much for joining us on the Kidney Corner. You're always welcome to come back. You've been inducted.
All right.
With us, and we'll definitely be in touch with you, and I hope that individuals who see this will have more questions, and I hope it's okay that we can reach back out to you to get some of those questions answered.
Absolutely, more than okay. I'd love to be a person that you can contact. Love doing this. I don't do many things like this, so it really is an honor and a treat. And especially because it's such a topic that's so near and dear to both of our hearts. So it's really been an honor just to be talking to you today. So thank you.
Thank you. I'm going to place you backstage for just a short time, and I'll be right back with you. Thank you, Dr. Julie.
You're welcome.
All right. So again, thank you all for joining us here on the Kidney Korner Podcast. Make sure you share, you click. If you're watching us on YouTube, click the subscribe button, share this with a friend, a family member who you may know that's dealing with kidney disease. I know that it will be helpful for them. A lot of great information. If you have any questions or just want to comment, hey, it's been rolling at the bottom of the screen the whole time. You guys can contact us at info@getinposition21.org or visit our website at www.getinposition21.org. And as always, folks, make sure you get in position as it relates to your health. We see you guys soon. Take care.